Hi, my name is Dr. Samuel Pegram. I'm a rheumatologist, and I would like to welcome you back to the living room. That's RHEUM, as in rheumatology, a place where we discuss rheumatologic issues always from the patient's perspective. At our last visit, we talked about the disease process, osteoarthritis, and today we're going to talk about treatment of osteoarthritis. Now, like all things in life, there's good news and there's bad news. So let's get the bad news out of the way first. There is no disease-modifying therapy in osteoarthritis, meaning medicine is to prevent the progression of disease or reverse the changes over time of osteoarthritis. But the good news is that there are a wide variety of effective modes of treatment that allow patients to remain functional throughout the lifetime of their disease process. So it doesn't mean that patients with osteoarthritis have a bad prognosis. In fact, quite the contrary. It is a very slow to progress form of rheumatism. So there's lots of time to modify therapy to the individual's needs. Standards of care are anti-inflammatory agents, analgesics, local joint therapy, and also surgical intervention. Now, anti-inflammatory agents have been the mode of treatment for osteoarthritis since the 1960s. And there are a number of anti-inflammatory agents, many names of that you recognize, ibuprofen, naproxen, etc. All of them are effective, but they should be tailored to the individual's needs. And so your rheumatologist or your primary care physician will select for you which one may be best. Also, all of them not only help with pain, but they decrease inflammation, stiffness, swelling, limitation in range of motion, so very effective drugs. But there are some patients who have to be cautious with the use of anti-inflammatory agents. Patients who are on blood thinners or anticoagulants, patients who have peptic ulcer disease or gastrointestinal bleeds, patients who have kidney problems, and patients who have had heart attacks. Those patients should use these drugs sparingly and only under the care of their rheumatologist or primary care physician. When used appropriately, they are very, very effective drugs and can be used for long term. Now, in some patients, the anti-inflammatory agent is not enough. And so you can supplement it with analgesics. And in patients who can't take anti-inflammatory agents, analgesics are the primary mode of treatment. The primary analgesic that is used is Tylenol, acetaminophen. And it is often very effective as monotherapy in patients who have osteoarthritis. Also, always under the care of their physician because you do not want to exceed recommended dosages. In patients who don't quite get adequate control with the analgesic alone and they're not intolerant to anti-inflammatory agent, the combination is perfectly safe and a good idea. In patients who don't fare well with Tylenol, they can use narcotic analgesics, and that is an appropriate treatment for patients who have osteoarthritis, but always under the care of a physician who is familiar with the particular analgesic that they are giving and also know the appropriate levels and make sure patients don't exceed those inappropriately. In patients who fail all of those modes of treatment, there is local therapy to the joint. For example, there's topical anti-inflammatory therapy, diclofenac gel as an example. It works where you put it. And for moderately severe, it's not a bad treatment in those patients who can't tolerate oral anti-inflammatory agents or analgesics aren't effective. They are generally not as powerful, or it is not as powerful as oral anti-inflammatory therapy, but again, a nice adjunctive mode of treatment. In those patients who don't improve with oral or topical anti-inflammatory agents, there's treatment into the joint itself. Cortisone can be injected in multiple joints and is always, again, adjunctive, never the primary basis of treatment. And we try to limit injections into the joints to about every 3 to 4 months. If the requirement is more frequent, then it says that we need to do better with some other mode of therapy. But cortisone can be placed in the knee and the wrist and the hands and the shoulders, so it is very versatile. There's also medicines called viscosupplements. These are gel-like substances that are injected primarily into the knee. They're almost like lubricants. They help the joints move a little bit better, and they are effective in moderately severe disease. In patients who have advanced disease with significant loss of cartilage, they are not worth your time or money. There are other types of modes of of local therapy that have been used here of late, such as platelet-rich plasma and stem cell modes of therapy. Those need to be used carefully and with discretion because they have not been approved by most insurance carriers, and they are also very, very expensive. And there's not a lot of great data that suggests that it's more effective than the other modes of therapy just mentioned. And then finally, in those patients who fail all of those modes of therapy, there's surgical intervention. A lot of patients hear surgery and they're immediately afraid. Well, don't be. Because surgical intervention, particularly for hips and knees, has been the greatest advancement in the treatment of osteoarthritis to date. And they are effective in the vast majority of patients, and they are done more commonly than most surgeries, other surgeries in this country. Patients are no longer in the hospital for weeks at a time. They're generally in the hospital less than 3 days, and you walk on the day that you get the joint replacement. And there are other modes of surgical intervention, such as synovectomies and arthroscopic procedures. So as you see, we've got a wide variety of modes of treatment for osteoarthritis. So there's lots of good news. And that's what we prefer here in the living room, good news. And we have lots of it for you as we go forward and discuss other disease entities. At our next visit, we're going to discuss a very common form of rheumatism called rheumatoid arthritis. I look forward to discussing it with you at our next visit here in the living room. Bye-bye.